Today I am going to talk about basic life support and advanced cardiac life support. I can see all of you very excited and very keen to learn. Thumping the mannequin. Umesh is very happy. Chia, Ramsey all seem to be very good. Now let me tell you, suppose you are walking on the street and in front of you see a man falling on the ground. Then what will you do? What are your responsibilities? What are your duties that you perform to help this person? Now, if you see such a person, it is possible that he might have fallen asleep or he is drunk. To know that, you have to come nearer to the person and you have to just ask him, hello, 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 hey, what has happened to you? Are you okay? If he doesn't respond, it means he is perhaps unconscious and he is not sleeping at all. He is not drunk. He is unconscious. So that way you establish that the person is unconscious and he needs a very immediate help. And you can do that, as I said, that by going nearer to the person and tap his shoulders, ask him, hello, 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 hey, hello, what happened to you? Hello, 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 are you okay? Are you okay? Hello, hello, hey, come on, are you okay? Are you okay? He is not responding at all. That means you have to call for help. And till the help comes, you have to give him a basic life support. You have to support his life. What are the basic needs and how to do that? To do that, you have to first judge that your life is not in danger and the situation is not dangerous, that it may cost not only the person's life but your life. So you don't have to perform the basic life support, rather you have to move away from the danger area, or you can take this person away from the danger area and perform the basic life support at a safer place. Now how to do that, as shown here, I put one hand on the forehead and I put the hand not on the chin, because if you try to put hands on the chin, it may close the airway. Rather you have to perform the previously there was a protocol. The BLS protocol was A, B, C, D. A is for airway, you look airway. B is for breathing, C for circulation, and D for defibrillation. So for airway and breathing, you just check that there is nothing in the mouth, everything is okay. And if everything is okay, put two fingers at the angle of mandible. And once you bring the face close to the patient and count for 5 seconds. Check whether his breath, you can hear his breathing, or his breath is striking your cheek, or his chest is rising and falling, by counting 1 in 1000, 2 in 1000, 3 in 1000, 4 in 1000, and 5 in 1000. So for 5 seconds you have to check these things. If there is that you are not hearing any sound of breathing, you are not seeing chest is rising and falling, that means the patient's respiration is ceased. Patient's respiration has stopped. He has gone into respiratory arrest. Then what will you do? You also you have to give to rescue breaths to this person, because there is no breathing at all. So you close his nostril and bring your mouth close to his mouth and seal his lips with your lips. There should be a tight seal. We call it as mouth to mouth breathing. And you give 2 rescue breaths to this person. So I give one, this is one, then I release the fingers, then I have to give one more. So one more breath is given. So 2 rescue breaths given. Then I will see whether his circulation is also stopped or his heart is beating. So let me check it by going to the front of the neck, moving downwards to Adam's apple, going then laterally and feeling the carotid pulse for 10 seconds like this. 1 in 1000, 2 in 1000, 3 in 1000, 4 in 1000, 5 in 1000, 6 in 1000, 8 in 1000, 7 in 1000, 8 in 1000, 9 in 1000 and 10 in 1000. So during these 10 seconds I am not feeling any carotid pulsation. That means that his circulation is also stopped. His circulation is ceased. His heart is not beating. He is in cardiopulmonary arrest, or commonly called as cardiac arrest. So you take the center of the chest between 2 nipples, put your hand as I have shown, interlock the fingers, stretch the arms, straighten the arms and put your weight on the arms and give 30 compressions. So you have to give 30 compressions. You have to give it at the rate of 100 compressions per minute. You have to do it in 30:2 ratio. That means 30 compressions and 2 rescue breaths. You have to complete these 5 cycles in 2 minutes. And the depth of compression should be about 2 inches. And the technique should be push hard and push fast technique. Since this body is little bit elevated, so I cannot put my weight on the arms. Actually the person should be at very low level so that you can easily put a weight through your arms on the patient's chest, so that it gives a very good chest compressions. But since in this skills lab it is at higher level, so it may not be. So I give it like this: 1 2 3 4 5 6 7 8 9 10. 1 2 3 4 5 6 7 8 9 20. 1 2 3 4 5 6 7 8 9 30. So 30 compression is given. Now I give again 2 rescue breaths. So closing his nostril, opening his mouth. 1 2. So 2 rescue breaths given. I will resume the cardiac compression. 1 2 3 4 5 6 7 8 9 10. 1 2 3 4 5 6 7 8 9 20. 1 2 3 4 5 6 7 8 9 30. So 30 compression is given. And I will again give 2 rescue breaths, because I have to give it in the ratio of 30:2 as I said, and I have to do it 5 times. That means the 5 cycles I have to complete, and that too I have to complete in 2 minutes. So after 2 minutes, once 5 cycles is given, I again look for breathing. So patient's breathing has not been restored. I again look for circulation for 10 seconds, and I feel that there is no carotid pulsation and patient is still in cardiopulmonary arrest or cardiac arrest. Now what should I do? That means I have to continue. I cannot stop at all. I have to continue the cardiopulmonary resuscitation. I have to continue the chest compressions as well as give the rescue breath till the help comes. And if the help comes, they got a doctor with them, then no problem, I can transfer this case to them. Or if they don't have a doctor with them, they need my help, I will go along with the person in the ambulance and will try to go to emergency ward, where the patient can be dealt nicely. And I have to continue this cardiopulmonary resuscitation even in the ambulance. I never have to leave this chest compressions or rescue breaths. I have to go on giving it till I reach the emergency department. Even if the patient is on the trolley and he is being transported from ambulance to the emergency, even he is on trolley, I have to continue cardiopulmonary resuscitation till he reaches the emergency department. And once he is in the emergency department, then you know that in the emergency there are team of doctors like you are here. So you consider yourself you are the team of doctors and you have received this person who was given cardiopulmonary resuscitation throughout the journey as well as at the scene of casualty. I never stopped giving him cardiopulmonary resuscitation. I was continuously giving him the chest compressions and all that. Even now it is not stopped and patient is now in the department, so you have to look after. So what will you do? So these emergency doctors, they are well trained because they get these cases now and then. And one of the experienced doctors will act as a leader. The other should not make a noise, the other should remain calm, and they should not get panicky. They just have to follow the orders of the senior person who will give them different tasks. Some will be on IV line, some will be connecting the person with the cardiac monitor, another person will be trying to prepare for defibrillation, and another person will be on securing the respiration. Because I cannot give now two rescue breaths here. It is you who have to now give the person, either you have to give him oxygen through, you can do the bagging by putting the ambu bag, or you can connect the person with the ventilator. After you attach him with the oximeter and see his oxygen level. If his oxygen saturation is 0, you don't have any alternative but to intubate the patient and give him the ventilation. That is what we have to do in the emergency ward, and each one will be doing that work. Now you can see here that the person is connected to the cardiac monitor. We see he's having the fine ventricular fibrillation, BP is not recordable, oxygen saturation is 0, and he is totally in cardiac arrest with ventricular fibrillation. Normally the cardiac arrest people, they come with ventricular fibrillation, but sometimes they will come with asystole or they will come with agonal bradycardia, in which case you have to give adrenaline atropine. Atropine nowadays is not given because they say it is not much effective. So I see here that Ramji is setting up the IV line. Patient has been connected already to cardiac monitor, and Umesh is giving the cardiac compressions. So everybody is doing work. Everybody is trying to revive this person. And the Chia will just secure the respiration, and she has to take care of respiration. So you have to you cannot give now breathing by you cannot give rescue breaths by yourself. You have to give it by ambu bag, or you have to intubate the patient, or you have to give by ventilator. That's how you have to go here. Everybody is doing his work. So you get the ambu bag. Now ambu bag is here, and you put the mask, oxygen mask, right, connected to the ambu bag. Hold it in a C-shaped manner like this, the way I am showing you, and start giving the breaths by compressing the ambu bag. Chia, you come on this side. Okay, hold it. Yes, and Umesh, you carry on with cardiac compressions, and Chia has to give 10 breaths per minute to this person. And how will she give it? She will give it, she will count within herself 1, 2, 3, 4, 5, 6. At 6 she will compress the ambu bag. Now again 1, 2, 3, 4, 5, 6, and she will compress it. So this way she will give around 10 breaths per minute. So no need to give rescue breaths. The cardiac compression is going on, the oxygenation is going on through ambu bag, and we see that there is no we put the oximeter has been also attached here, which shows us the oxygen saturation, and the cardiopulmonary resuscitation is still going on, but it is in advanced form, that we have connected the person with the IV line, and if you can give 1000 ml to this person, you can give that very quickly, because we need to give him a fluid so that his cardiac output becomes okay, his BP is restored. And at the same time, you can't keep on giving the respiration through ambu bag. You have to think of intubation, because oxygen saturation was not coming up by bagging. So you take the endotracheal tube, you make it a hockey stick like the way I am making it, and you have to insert this endotracheal tube into the trachea through laryngeal opening, hold the Macintosh, the laryngoscope, and give a forward and upward thrust. Don't tilt it, it should not touch the teeth behind, and insert the endotracheal tube by seeing the laryngeal opening. And once the endotracheal tube is in, you take out this laryngoscope, hold the endotracheal tube. You have to hold it, otherwise it will slip out. So be sure about it, it is held in position, and you take the ambu bag and connect it with the endotracheal tube. So take the bougie out, or style it out, connect it. It should go up to the mark of 19, the endotracheal tube, or 20. The another person will see that the endotracheal tube is in position by auscultating. So you auscultate at the right side infraclavicular region, the left side infraclavicular region, the right axillary and the left axillary, 4 places. And then you auscultate at the epigastrium and see that there is no gurgling when she is giving the breath through the ambu bag. If there is gurgling, it means it is not in position, it is in the GIT. At that, or if there is no gurgling, it means it is in right position, and you can give now breaths through endotracheal tube. And this endotracheal tube can remain in position, or it can remain secured. If you give 10 ml, you inflate by the side there will be another tube, and through this tube you give 10 ml, so that the balloon around at the lower end, the balloon around the endotracheal tube is inflated and it does not slip out. So it is secured. Now you can connect it with the ventilator, and respiration can be given through ventilator. The patient is on ventilator, you don't have to worry about his respiration now. The only thing you have to do, you have to keep on giving the cardiac compressions. The another person will take the defibrillator. The first thing you do in the ventricular fibrillation is to defibrillate. Now she has taken the 2 paddles of the defibrillator. She will charge it up to 360 joules. That means switch on the defibrillator and put it at 360 joules. And these 360 joules will be transferred to the paddles by pressing the charge button. So she presses the charge button, 360 joules will come on the paddle. And now she has to put it on the person's chest, but while putting it, everybody has to clear from the bed. So she will say, I clear, you clear, so that everybody is away from the bed. See, it is only at this time that you may stop doing the cardiac compression, because she has to defibrillate the patient. Otherwise there is no way. So you put the one pedal to be put on the right infraclavicular, another to be put at the apex, and she delivers the 360 joule by close contact with the surface of the body. Correct. So 360 joules given. She is continuing the she is continuing with respiration, you are continuing with cardiac compressions, and the person is looking whether any change has occurred on the monitor or not. If there is no change at the monitor, so the person on IV line has to prepare the adrenaline, and adrenaline is to be given after the shock, and it should be about 1 milligram adrenaline IV, and followed by 20 ml of saline for flushing the vein. So after every shock you have to give a drug. In other words, we can call it shock drug therapy. So the Ramsey is taking the adrenaline. He is taking the adrenaline and he is giving 1 milligram of adrenaline after shock, and followed by 20 ml of saline for flushing the vein. The cardiac compressions will go on. The breathing is go on. The another person will look at the watch and he will inform the others that 2 minutes have passed, because every 2 minutes you have to give shock and drug every 2 minutes. So he says that 2 minutes are over. When 2 minutes are over, you have to give one more shock. So one more defibrillation is given. So you clear, I clear, 360 joules given. Correct. And after the shock, one more adrenaline injection to be given when we see there is no change. The Ramsey is giving one more injection IV, 1 milligram IV in the adrenaline, followed by 20 ml of normal saline to flush the vein. The cardiac compression is going on. Another person is seeing the time when 2 minutes of cardiac compression is over. So 2 minutes are over. Now she has to give again a shock. So you clear, I clear, thadak. So the shock given, and after the shock he has now choice. The Ramsey has now choice whether to give adrenaline third time or not to give adrenaline. Some people they give third time adrenaline 1 milligram, and some people they substitute the adrenaline with vasopressin. So you got a choice, you can give vasopressin or you can give adrenaline. The vasopressin can be given as 40 units IV. That too will be followed by 20 ml of normal saline for flushing the vein. So third time you are giving 40 units of vasopressin. You gave two times adrenaline, now third time vasopressin. So Ramsey is giving the vasopressin 40 units one time to this person. Now so far we have given 3 shocks. We have given 2 times adrenaline, 1 time vasopressin, and there is no revival of the patient. Now again what we do is we give one more shock. So the shock given 360 joules. The cardiac compression is going on by Umesh, and after this the adrenaline part is over. We don't have to give now adrenaline. What we do is that we give amiodarone 300 milligram IV. IV 300 milligram amiodarone is to be given, which the Ramsey is giving. And the cardiac compression is going on, respiration is going on through ventilator, and again when the 2 minutes are over, so we have to give another shock, and she is ready to give another shock after 2 minutes of cardiac compression. So she is ready, yes, ready to give shock. You clear, I clear, the shock clear, all of you clear, yes. So shock 360 joules given and resuscitation going on. Now what you do, you have to give again amiodarone, but in the dose of 150 milligram. So Ramsey giving 150 milligram. The resuscitation will continue, and when 2 minutes are over, he will say 2 minutes are over. 2 minutes over, there is no change in the rhythm, in oxygen saturation or BP. Patient still in cardiac arrest. 2 minutes over, the shock ready, thadak, so shock given, resuscitation to be continued, and Ramsey will give another drug, lidocaine now, which will be given 1 milligram per kg IV, followed by 20 ml of saline for flushing the vein. And this can be repeated 2-3 times, no problems. And after this, now what to do? The resuscitation going on, and 2 minutes is getting over. She is ready for another shock, and she is ready to defibrillate. It is really intractable ventricular fibrillation, not affected by the drugs. Very difficult situation. So the shock given 360 joules, resuscitation to be continued. The Ramsey will give now the drug what is called as magnesium sulfate, and magnesium sulfate is to be given as 1 to 2 grams IV as usual, followed by 20 ml of saline to flush the vein. Now so much time has elapsed, there are no chances of the patient getting revived. Patient has gone now in acidosis, and now is the, so she has given the shock. Now is the time, after the shock, now is the time to give sodium bicarbonate. The sodium bicarbonate is to be given 1 milliequivalent per kg body weight IV bolus, and the image got exhausted, so another person is doing cardiac compression. This can happen in real situation in the emergency wards. When one person is exhausted, the another person takes over, and we have done our best. All the drugs are exhausted, all effort is done. So much time has passed from the point the person fell on the ground. The basic life support given, patient brought to emergency ward. The team of doctors taking over the control, but no revival. Now, some patients will be lucky, they can revive at first defibrillation or first or second or third injection, and some people are unlucky, they will not revive at all, so they are to be left to have the peaceful death, because you know the death is unavoidable. But some patients who are lucky, they can revive, like this person, and you can see his ECG, his heart getting normal rhythm. It has been successful. The patient's rhythm is restored. He is not now in cardiac arrest, and things are getting better. The oxygen saturation is coming up, and the BP will come up. The patient is lucky to survive. You can see the rhythm here. Yes, his BP and oxygen saturation still not established, but it is going to get established. And it is all because of your efforts that the revival of circulation and revival of respiration has taken place. The person has come out of cardiac arrest, and I wish you all the best for participating in this exercise. And whenever in life you come across with a person who has suffered cardiac arrest, please recall and remember this exercise and apply this to such patients, and hopefully the patients will be benefited. And I hope that in future, this is actually the foundation which I have laid down, and on this foundation you have to build your knowledge. You have to practice more and more so that you become perfect and you serve the people. And as you know, the service to the people is worship. Be always kind and compassionate to the people who are sufferers, who are in pain, or who are in cardiac emergencies. I wish you all the best, and I thank you. Thank you for the MMC giving me an opportunity to disseminate this knowledge among medical doctors or medical students, and I hope that it will be helpful to all those who are in this profession. Thank you.